Okay, we can go.
Okay. Okay, so we can kind of go ahead whenever you're ready, Logan.
I
Um,
am ready.
okay, so my name is Olivia. I am a physician assistant practicing in cardiothoracic surgery.
My name is Logan. I am a physician assistant. I practice in outpatient internal medicine, primary care.
And I guess today we're just going to go over what to prepare for on your clinical rotations and how to, get in that mindset, tips and tricks along the way. So we will go through all of these slides with you. And this is basically everything that we are going to cover. We'll do a giveaway at the end. So one person who signed up for this webinar will get an email and find out that they've won the giveaway. So that's very exciting, which is going to be a Rosh Review Pants Power Pack. So just will help some helpful pants prep with that giveaway. Okay.
All right, the transition from didactic to clinical year. So a lot of stuff changes in this time. You're used to going to school every day, being around the same people in class all day. Things get a little bit different when you're moving on to clinical year. So every 4 to 6 weeks, you're at a new site, you're working with a new staff and a new specialty. So it's a whole, basically, you're starting a new job every 4 to 6 weeks. So it's constant changing and being adaptable to that. So molding to whatever environments and stuff that you're in. A lot of people have trouble with that, and that's something you just kind of have to get used to, of like, this is how I prepare, and we're going to help you through that process too, of explaining what you should do beforehand, what you can't really do beforehand, all that kind of stuff.
Yeah. And as soon as you get comfortable, it'll be time for the next one. So that's
Yep.
the best part about all of it.
Yeah.
Okay. So overall, just like preparing for your first day, make sure that you know what you need to have done before you get to that clinical rotation site. A lot of PA schools now are thankfully kind of guiding you in the right direction, making sure all your vaccinations, ACLS, BLS, all that kind of stuff is up to date before your rotations if required. But certain sites have other things that they may want you to do. I know when I was on rotations, it was right when COVID was going on. So we had to do daily COVID screenings and all that kind of stuff to make sure that I was able to participate in the rotation. So that's going to be your responsibility to make sure, double check that you're not missing anything that the hospital system or office may require from you.
Yeah. Other things you want to think of is like making sure you know where to park, that you're not going to get in trouble for parking somewhere, you're not parking in patient parking. You're kind of knowing where you have to be. You're not showing up late. So something we always did was the trial run the day before. So you drive to your clinical site, you see, where am I going to park? What door am I going to use to get in? Make sure you have your ID, your badge, or any of that. And if you don't have that yet, coordinating when you're going to get that for your first day as well.
Yeah, absolutely. And make sure if you do your test drive at 7 p.m., you allot for the morning traffic, depending what time your shift is. A lot of times, if you contact your preceptor beforehand, they are more than happy to tell you, what should I wear? Am I showing up in scrubs? Am I coming in business casual? If for some reason you contact your preceptor and you don't hear back and you don't know what to wear, I would assume business casual unless you are told otherwise. I think that's always a safer way to go. I don't know what you think, Logan, but
Yeah, I think it's always safer to do business casual. Most of the sites you're going to be in, and obviously except for like ER, you're basically going to be in business casual. Um, and if you don't hear back from your preceptor, you can always try to find a different, like, go through your clinical coordinator at your program, figure out who was there before you, and see if they have like a different contact number or something like that, and then just ask them what they did. Normally that's really helpful as well.
yeah, absolutely. And also, ask, obviously you need to know when you need to be there, but also ask if you could get some contact information for the day of, especially if you need to know if it's a big hospital system and you're walking in the main entrance and you don't know where you're going. Usually they'll be pretty amenable to helping you find your place. You can even ask, hey, is there a place to store my lunchbox or something? Or should I, just so you're prepared, so you're not finding yourself in a situation where you come in with too many things or not enough things, all that kind of stuff.
Yeah,
So another thing to just make sure is that if you had someone who was in this rotation before you, or somebody who was, maybe less than pleased with this rotation that may have been at the site prior to you. You're kind of always going in with an open mind. And if someone really enjoyed a rotation, that's great, but sometimes you're going to get some not so positive feedback. And that's because we all have our niche and it's not all going to be the same. So you never want to go into a rotation with a negative attitude or a negative mindset, because it's just going to put you in a bad position overall.
Yeah, I think that walking, ultimately there's going to be some people that people mesh with and some people that people don't. But like one of my best friends in my program hated one of the attendings from our surgery and was like, so like, she was like, you're going to hate it. It's going to be awful, blah, blah, blah. We like clicked. We had a great time. He ended up like being one of my references for my current job. So you never want to take somebody else's word for it. You don't know what their situation was and their experience was. And also, those people are helping you, telling you what you need to know, what you should study, things they typically pimp on, all that kind of stuff. So just try to get as much information as possible from the person that was there before you, because sometimes that ends up being really helpful. And even if they didn't have a good rotation because they didn't know that stuff, well, now you have all those tools that you can kind of go in a little bit more prepared.
Yeah, absolutely. So in general, obviously, the first impression is so important. As you can see from Forbes magazine, it says that it only takes 7 seconds for a first impression. So that's not a lot of time to try and get in the good graces of your preceptor.
Yeah. And those 7 seconds are really a lot of like, are you on time? So are they waiting for you for the first like minute that they met you? And do you look right? Are you like ready? Are you prepared? You're not rushing. Your hair is done. It's not wet. Like all those kind of things. So just making sure like your appearance is there, you're there. A general rule of thumb I always had was making sure I was there 15 minutes before I was actually supposed to be there. That way you account for getting lost or not knowing where to park or like traffic or whatever. If you have that extra 15-minute buffer, you're gonna be really, really happy. And they always like to see you show up 5 minutes earlier than you're supposed to too. The
Yeah,
worst thing you can do is make someone wait for you.
definitely. Like, you do not want them to wait to get their day started for their clinical student to come. And I agree, always a lot time for getting lost, because it will happen at least once. Make sure
Probably multiple times.
yeah, probably multiple times. It's definitely harder too with commutes and stuff like that when you're in bigger hospital systems, bigger cities. It can be a little more confusing, especially if you're traveling for your rotation somewhere that you're not familiar with. So just make sure that you are doing all those things to show up on time. And when you do come in, just like Logan was saying, make sure that you look appropriate. You have a you're well groomed, and you're wearing what they asked you to wear. Never underdressing for a clinical rotation site, and make sure you have your name badge on and you look like you're supposed to be there and you're ready to be there, and you don't look like you just rolled out of bed and showed up at your clinical site. So
Yeah,
even
and if
though
you have your white, oh, sorry.
I was just gonna say, even though that's probably what happened, you probably woke up and then you got ready and then you left, but you don't want to look like that.
Yeah. Yeah, and if you're gonna wear your white coat, make sure your white coat is pressed. You never want like a wrinkly white coat, or if it's like there's stains on it or whatever. So make sure you're spending the time and money to get that dry cleaned or to press it at home yourself or something. You never want it to look like you keep it in a ball in your car, even though you probably do.
That's a very
Um,
good point. Yeah, pen mark stains or something like that by rotation number 3. So
exactly. Yeah. So you can get some of that stuff out. But yeah, the making sure your white coat is right, and another thing that we always did was if you have a car or even if not, honestly, keeping an extra few things like deodorant, breath mints, mouthwash, a change of clothes in your car, extra shoes. You never know what's going to happen on your rotations. My very first day of my very first clinical rotation, I spilled betadine down my white coat. So you never know what's going to happen. You can get blood squirted on you. You can be in surgery and get something squirted on you. So keep an extra hygiene kit and an extra change of clothes with you just in case anything should happen. And then just keep that with you during clinical year.
yeah, absolutely. Great point. So your first impression, I think the main point of this slide is just to tell you that it is more than just your first impression with your preceptor.
Yeah. So you want to make sure something that I think a lot of people overstep is that they think they're better than the support staff. I think med students do a little bit more than PA students, but everyone does do it. The support, everyone is there as staff, and you are a guest in that space. So the support staff is going to be your best friend. They are, if you're nice to them, they're going to be nice to you. They're going to be making sure you're getting in on the cases that aren't necessarily with your preceptor, or they're like telling you the processes like one step ahead so that you're ready when your preceptor is ready for you. So I always went in on the first day. I made sure I knew all the techs, the MAs, the front desk, all of those people, because those people are going to be really, really helpful to you as far as the administrative and getting things early and getting things done. So if you get the support staff on your side, you'll have your preceptor on your side too.
Yeah, absolutely. And also, the support staff can provide a lot of really great opportunities for you, especially in certain rotations. Emergency medicine, they'll make sure that they call you into the cool cases or anything that maybe it's not your preceptor's patient, but there's something that you should see as a student. And you want to make sure that you are asking support staff, what can I learn from you? Ask them questions. I know when I was on my ICU rotation, I did a lot with respiratory therapists. We do not learn that much of mechanical ventilation in PA school, and I learned so much from them. And it really helped my understanding. I still think about it to this day. I work sometimes in the ICU, and I am still using the things I learned from them. So I definitely think that that's very important, because it'll make your all-around experience better, whether it be them teaching you something or if they just are including you in the office lunch or something. You want to be on good terms with them. So
Yeah. And another thing too that so I was in school before COVID, and I did like in my urgent care rotation, I was with like the MAs and the techs, and I was just practicing nasopharyngeal swabs for flu tests. And because obviously it's something you don't really do that much in PA school, it's not a critical skill. And then COVID hits and everyone's doing NP swabs for COVID PCRs. So you never know when those things are going to touch in.
right.
Um, and now I work in a really small private practice. So a lot of times I'm doing my own vitals, I'm doing my own blood draws and that kind of stuff. So, phlebotomy is something that you can always, always, always use practice on, and especially practicing from somebody who does it all day, every day. So, even shadowing and watching people do IVs and phlebotomy, if you're doing nothing, go and do something. It's better than sitting around. So
Yeah.
always make use of any of that time. So your preceptor's a tool, but so is all the support stuff around you, even if you're just asking them to go and watch them draw blood. They like teaching too.
Absolutely. And I think also, what this slide is talking about is that first impression with your patients, because you are a student and you should be introducing yourself as such. But make sure that you're coming off as confident, not arrogant in a sense, but make sure that you are confident in your abilities, that you're going in with a clear, concise plan of what you're going to do. I would also make sure that you remember that you are kind of taking these people's time a little bit, because your preceptor will have to do a physical exam as well. So if I were, when I was a student, I would say, thank you so much. I'm just going to do a quick exam. My preceptor is going to come in here after me, depending on what the situation is. Yeah, and present yourself they'll be happy to help you if you come off in a way that is very appreciative and confident.
Yeah, absolutely. And just make sure that you answer their questions if they have them. And if they say, I don't really want to talk to a student, don't argue with them. You are, again, you're a guest in this space. You are not staff there. So if they say they don't want a student or they're not comfortable with it, or, at 5 minutes in, they say, like, can you just bring the provider in? Just say, of course, I'm so sorry, I'll go grab them.
Yeah.
You're a student, you're a guest in the space. If they don't want to talk to you, they absolutely do not have to talk to you.
Yes, I agree with that completely.
Okay.
All right. So this is just kind of going over a little bit about what you should be bringing. So obviously we already talked about attire. You're wanting to ask your preceptor what to wear, and just like Logan was saying, have extra of it because you never know what could happen.
Yeah. And the comfortable shoes is a big thing too. And if you're gonna wear uncomfortable shoes, do not complain about it. Nobody cares. So if a lot of the sites are business casual, there were days that I had to wear a full suit. I absolutely was uncomfortable. I absolutely did not tell anyone. Nobody cares that you're uncomfortable. You're a student, you're a guest there, you're lucky to be there.
Yep.
So if your feet hurt, that's okay. You can complain about it to somebody after you get home.
Yep. Absolutely. And then for accessories, so this kind of varies, I think, just based off of what rotation you're on. Obviously, always bring your stethoscope. I would always have a pen light on me, especially in almost every setting. That can be very useful. You never know who's going to need a light, and you could be the one that has it. Certain rotations, you may even need to bring otoscope, but probably not. I would probably refrain from maybe bring it all on the first day and then scope it out. But most patients, most outpatient offices, and obviously hospital settings, well, they'll have those in the room for you. So you don't want to be carrying too much stuff. I would definitely bring note-taking material, and I would definitely utilize it, especially if your preceptor says something important. One of the most annoying things is if you tell someone something and then you have to repeat it. So definitely be taking notes. I think not only is that a good practice for you to learn, but it also shows your preceptor that you are eager to be there, and that you're really taking what they say seriously.
Yeah, and I think having a notebook and pen always is a little bit better than taking notes on your phone too. So that's just something to be a little bit mindful of.
Oh yeah, definitely.
Um, what other things did you have any like bonus stuff that you brought to your rotations? Like I always kept like uh little thing of Mio Energy in case I was tired, Advil in case I got a headache, and a protein bar in case I got hungry. And those were like my three things I kept in my bag at all times. Did you
Yeah,
have
I
anything like that?
I had my little like Maxwell. I don't know if you know what I'm talking about, but it's like a
Yeah,
little
yeah.
tablet. I love that, especially for the neuro exam and like emergency medicine rotations. And I would just look at it, before I went into any room that I thought I might have to do a full neuro exam on. Um, I loved that little thing. I have my notebook. Trying to think, fun things wise, I didn't have too much. I had like a big thing that I kept in my backpack that was just like practice questions in case I had an extended lunch or something and I could do that kind of stuff. Um, but yeah, and then always hand sanitizer because you never know when you're not going to have hand sanitizer, and especially it was COVID, so I had hand sanitizer, a ton of it.
Yeah, those are all good ones.
Yeah. As far as references, I think it's obviously rotation dependent, and you can definitely ask your preceptor before you start. Is there any references you would recommend? And they may just tell you, I have plenty in my office. Don't worry about it. That's a very, very easy thing that could happen. I know, there's a fine line between getting too many references and wasting money, and then having nice references that'll be important. So I would definitely use your resources as far as your preceptor and classmates, see what really helped them. And
Hmm.
not overextend yourself. I bought like a little pocket surgery book. It's like you can't even have that on you half the time. So I don't know why I got that, but it didn't really help me much. I don't know if you have anything like that that you bought and you were like, I don't need this.
Yeah, I bought like a pocket like ER quick facts thing. It was like $50. I didn't open it once. It was stupid. Honestly, most of the stuff like my school gave us up to date, and that's what we were checking mostly for everything. So up to
Yeah.
date, and then I used the Maxwell a lot too. That was really nice just for like those random things and like conversions and whatever.
Yeah, that's
So
a quick, easy references that you will actually use versus like a big book of stuff that you're not going to be able to get through.
yeah, and like use your free apps too. So like I have the Hippocrates app where I look up dosages. And there's like weight-based calculators and that kind of stuff. One of my rotations was paper charting still, so I had like a BMI calculator because we had to put that on the chart. I'm like looking in my medical app on my phone. Oh, and MD Calc, that was a big one.
Yes, that's awesome. I agree with that.
I
I
love
still
it.
use that. I
I
still
can't
use
see my
that all the time.
phone. But yeah, I use that all the time. It's so good for your ER rotation too, to like perk people out and things like that. Um, so yeah, MD Calc's a good one.
Absolutely. Okay, good. Okay. Okay, so just kind of overall, you want to get the most out of your rotation, even if it's the rotation that you're never going to go into, which I went into my surgery rotation and I was like, I'm not going into surgery. Like, this is just a waste of my time. Like, I don't even know why I have to do this. And now I'm practicing in surgery. So, whatever. But it is kind of just like go into everything and try to make the most out of it because you never know what you're going to get out of that experience. Because you find out you love something that you really didn't think you would. So, but
Yeah,
overall, go ahead.
you can keep going. No, you
No,
can go.
that's I was just gonna say like the best thing to do is kind of have those conversations early and a lot of programs, I don't know if yours did, but mine kind of provided with like an assessment sheet that they had to fill out like an evaluation at the end of each thing.
Yeah, and we had rotation goals too. So it was like some of the things were like inserting an IV and all that kind of stuff. So I would go over that with my preceptor on the first day and be like, hey, this is like a list of things that they want me to do while I'm here. I just want to give this to you early so like we could, see if we can do that. Because sometimes you'll be with a preceptor and they're like, okay, I don't do like when I was in peds, let's say, they were like, she was like, okay, well, I don't do adolescents. I only do like newborns or whatever. So like we'll make sure to get you with like an adolescent person on like some days so you can do like this X, Y, and Z on the list.
Yeah.
So setting up your expectations of what you want and need out of the rotation along with what your preceptor does too. It gives them one, doing it on the first day also gives them time to prepare if they need to like pull somebody else into precept you for a day or whatever. You're kind of putting everything you have up front and you're making sure you're not having them cram and rush for you at the end.
Yeah, absolutely. And honestly, sometimes they just don't know. Like, how are you supposed to know? All schools are different. If
Yeah,
you have a student, you don't know what they need. And then at the end, if they fill out your evaluation and it says, how did Logan do with IVs? It's like NA because I didn't see any, because how would I know?
exactly. Yeah. So making sure you're prepared for them too, of like, this is what I need, this is what like. And I think there's also like this debate, which I don't know if you heard of this when you were in school. They were like, go into every rotation saying that's the specialty you want to go in. I think that is the worst advice. Some people I know did that. And I am in Olivia's boat too, where I like absolutely hated primary care and I said I would never do it. And that's the only two jobs I've ever had. Um, so you never know what you're gonna go into. And it's nice to say like, I'm thinking about this, but I'm really open. And they'll kind of gear things towards whatever your main interest is too, if you have like good preceptors like that. So
Yeah,
just be honest with
absolutely.
them, but don't say like I will absolutely never do this specialty. I hate it. Like
Yeah.
even if it's true.
Yes, yes. Like I knew I was not going to go into psych. I can tell you that right now. Like I was not going to go into psych. I think some people are made for it, and it wasn't me. Um, but I went in there like with an open mind because why not, right? Like that's what we need to do. And I think I agree with you completely. Don't lie. Don't say that you're really passionate, because then what's going to happen is you're going to get yourself in a situation where it's like, oh, hey, like you can go home, but you know what? You're super passionate about this. So why don't we stay a little bit later? We can do all this stuff with you. And then at the end of the day, you're just gonna get your it's not the right thing to do. It doesn't even make sense. I agree with you. I wouldn't do that.
And they're also going to hold you to a really high standard then too. If you're like, let's say OBGYN, like very much kind of like psych, like people like it or they don't. If you
Yeah.
go into OBGYN and you say, this is what I want to do, they're going to like grill you so hard because they're trying to prepare you for a job. And they wouldn't do that if you said, I don't want to go into OBGYN, but I'm looking for, like, I would never say I don't want to go into this specialty, but I would say, the top of my list is this, so I'm really open to anything. And I think that's a good way of saying like, these are the two or three things I'm thinking about doing, but I'm open to all specialties. I'm really excited to learn and see like what kind of things you guys do here.
Yes.
And it's just one of those things where, you're making sure that you're telling them that we have, um, that you're telling them that you have interest in everything too, and you want to see what they do. It's
Yeah.
ultimately 4 to 6 weeks. So like you can do 4 weeks of something you don't like and you can do it with a smile and you should.
Yes. Yes. Absolutely. I agree. Always kind of be honest and say, maybe this isn't for me. But it is funny that you say that, because it's like, yeah, if I went in and I was like, no, OB-GYN's for me, even though obviously that's not where I ended up. But if I thought that, if I was gonna gung ho, then my preceptor may be like, hey, like why don't you stay for the C-section or something? It could be like 7 p.m. Like, let's do this together. And like, if you weren't into it, she'd be like, nah, you go home. Like, I'll stay here. So you're just gonna bite yourself in the butt if you do that. So I agree with you.
Yeah.
That's a very good point.
And you'll like make your preceptors put in a lot of extra work that they don't necessarily have to teach you something you're never going to go into. So
Yeah,
it's like being respectful of their time too.
100%. And
Yeah.
also like when it comes to each rotation, uh, one other thing that you need to talk to with your preceptor about probably early is like, these are your goals. What do you want from me? Like, how do I fit into this practice while I'm here? And I think that's really important because it's going to be different. I had rotations where I thought I was acting like fairly independently. I'd see patients alone. And then I had some rotations where I was with the preceptor 90% of the time. I think it depends on their comfort level, on how far you are in your rotations, on what they're used to. Um, some rotations you'll write the notes. Some rotations they'll have you like write a mock note and go over it with them. I don't know if you have any input on that, but I've had a wide variety of what people wanted from me, and it's good to know right away.
Yeah, I had the same where I had some rotations where I was basically seeing patients on my own and they would just double check my work and go in and say hi.
Yeah.
And then I had other rotations where I literally shadowed for 6 weeks. So you never know which one it's going to be. And if you're on the side of, like, if you're on the side where you are doing a lot more shadowing, whatever, don't push the preceptor out of their comfort zone. So you can say, like, on previous rotations, I was seeing patients on my own, and then having you like come in afterwards. If that's something you'd be open to, that would be nice. But like, don't push them if they say no. So if they're not comfortable with something, then they're not comfortable with it, and that's
Yeah.
their prerogative too. You're seeing their patients at their job.
Yep. And ultimately, a lot of times when you are seeing patients by yourself, the preceptor still has to see them. So if they're running behind, if they're in a pinch, they may find themselves in a situation where you are kind of shadowing a little bit just because, let's do this because everyone wants to go home at the end of the day, right?
Exactly. And when I get behind at work, it happens all the time. And if you're in an outpatient clinic, you're bound to get behind because somebody comes in 10 minutes late. The last thing you want in those moments is like somebody like slowing you down even further. So
Yes.
just kind of read the room about,
Yeah.
sometimes aren't the best time to ask questions. So you should have questions and you should ask questions, but just be mindful of when you're doing that, what your preceptor is doing. If they're already multitasking, now is not a great time. Write it down and ask them at the end of the day or ask them during lunch or at another time.
Yeah, I agree completely.
Yeah.
Um, And then, also make sure, and this is kind of what we were saying before, resources. If you have downtime, I'm sure you'll know by like the first week if you're going to have downtime on this rotation or not. But if you do, make sure that you're kind of making use of your time wisely. It is still the middle of the day. I'm sure you have plenty to do. Um, so I would either say use that time to log patients or do some practice questions if you want to, whatever you need. But I would definitely have those resources available so you don't find yourself just sitting around. I knew when I was in PA school, sitting around would make me very anxious. So I always wanted to have something to do.
Yeah. And you always look better as a student that brought study materials versus a student that like sits there on their phone.
Yeah.
Um, so just be mindful that every second that you're there, people are watching you and they're going to be talking about it. So make sure that you're the good student. You're not like the lazy student or whatever.
Yep. I agree. Oh, and then just one more point. They were saying that if you have these rotation reviews at the end, which I think most schools do, it might be worth your while to midway through say, hey, how am I doing? Anything you want me to improve on? That way you can show your preceptor, one, you care, and two, you're not being blindsided with weaknesses that you didn't know about after 4 to 6 weeks that you could have maybe started working on at week 2. So I would always have like a mid rotation quick conversation. How am I doing? I had some preceptors that would organize this and it was their idea, and then I had some that would never talk about it. So I would say take that initiative if you can.
Yeah. One thing I would also add is on my first day, I would also normally ask something along the lines of like, what bothers you that students do sometimes, just so I can avoid doing that. And a lot of times they'll mention like students being on their phones or like not being interested or like getting a little too comfortable. So that's always like a good thing to go in with of like, okay, a student did this to them before and they like it really bothered them. So I'll be sure not to do that.
Hmm.
So like prompting them to answer sometimes is a little bit easier than just saying like it's always better to go into it knowing the mistake that's like one of their pet peeves rather than kind of being reactionary after you've already been doing it too.
Yep, I agree.
What's it
So
do when I'm oh go ahead.
no, yeah, no, seriously, what do you do when you're not there, right? Because we spend probably about 40 hours a week. What do you
Yeah.
do, Logan?
You don't get behind. This was like the classic mistake that people would make is like they just took an EOR, they just started a new place. They're like, okay, I'm gonna chill, I'm gonna take a beat, I'm gonna breathe. It's like the worst thing you can do. The first day of your rotation, figure out what your hours are, and then look at your blueprint and figure out your study schedule. For my school, we also had to do daily patient logging and it had to be inputted at like 1 week at a time. You don't want to get behind on your logs. We all made the mistake of like getting like 5 days behind on patient logging, and it makes like your weekend absolutely miserable.
Yeah.
So my big points are go in strong, make a study plan, and stay up to date with your patient logging. if you can do like, I feel like I was only really putting in like 2 to 4 hours a night after rotations, and that was pretty good enough for me. But I think if you fall behind, then you kind of end up doing those 6 to 8 hour nights, and that's
Yeah.
not fun.
Yeah, it's just overwhelming. And honestly, once you get to that point of like cramming and stuff, it's not as much, especially when you're preparing for like the boards, it's not as conductive to like healthy learning. Like it's not long-term memory at that point. Once you're just like if you do 2 hours a night and you focus on 1 to 2 topics, you're gonna really stay where you need to be. You're gonna stay on track. Easier said than done. But if you only have 2 hours, then you're kind of planning, if I skip an hour here or something, you have plenty of time to make it up, versus getting just super far behind or not doing anything Monday through Thursday and saying Friday, Saturday, Sunday, I'm just going to study the whole weekend.
Yeah. And like, if you keep it to 2 hours a night, it feels manageable. Like you could still have time to like breathe and relax. And I think that's always nice too, of like trying to stay on task, and then like you'll reward yourself at the end of the evening is that you have like a couple hours to wind down, watch movies and relax, or like go hang out with friends or whatever.
Yeah,
So yeah.
I agree with that completely. And I think like I use the PANTS blueprint, that's on the NCCPA website to kind of help guide my study strategies. And I try to organize them with, at the same time, my end of rotation examinations that I would have, my rotation specific exams. Um, it's very variable. You're not going to be studying the same thing that your friends are studying anymore. And I think that that's kind of a weird situation. I mean, I remember when we were all studying for peds and we were all going over the vaccine schedule or something. And now it's like they could be studying for women's health and you could be studying for surgery. It's very different. So you want to kind of set yourself up for success and see what's going to be on those exams, all while still keeping the biggest exam in your mind when you're creating
Yeah.
this plan.
Yeah, I agree. It's always nice to make sure that you're going off of those blueprints and you're being thorough. So I would use the PAEA blueprint, and then I would pull everything in from like Rosh review questions, and like trying to pull in from as many sources as you possibly could, making sure you were going to be complete and thorough, because those end of rotation exams, especially the PAEA ones, sometimes they stray a little bit off topic, and you kind of have to make sure you took a really deep dive into things. It's not very superficial. It's every detail under those topics is fair game. Side effects
Yeah.
of medications and like contraindications and all that kind of stuff. It's not going to be straightforward. So it's just they're pulling pants questions basically about anything correlated to those topics.
And I think also like you will learn so much more than you even think, on clinical rotations that will help with these exams. So I know a lot of times people would think about their job in clinical year as the number one job is to, take these tests and pass them and study. And when you're in, if you stay over in clinicals, then you're like wasting study time or something like that. But really, you are going to work every day and you are studying. You are studying for 8 hours a day on the job, and how much you get out of that is up to you, how many questions you ask, what kind of how you see your patients, but they, like Logan was saying, if they are more in depth and you're actually doing it every day, it will really help you if you take it
Yeah.
seriously.
Yeah. And I had so many times that I was taking those exams. I'd be like, oh my God, this is exactly like that one patient. What did we end up doing for them? This is what we did. This is why we did it. That's the answer to the question. So
Mhm.
if you're, especially if you're a person that thinks like that, every time I take exams now, I'm always thinking of like what patient I treated with it. So it's really, really important that like, you're really being mindful and actively engaged all day when you're at rotations. You're not just kind of going through the motions.
Yeah,
One thing we
absolutely.
haven't talked about yet is like, how do you prep for the next day though? So I would always, even if your preceptor signs off and goes home and tells you you're welcome to do the same, I always would recommend, especially when you're a student. I mean, you should do this when you're a provider too, but I know I definitely don't do that all the time. Going through tomorrow's schedule and seeing like what the chief complaints are for the scheduled visits, what surgeries you're doing the next day, all that kind of stuff, and just looking through, going over all of that to make sure you're as prepared as possible for tomorrow. So looking up like, how are they diagnosed? What imaging findings? What labs do you think you should order? All that kind of stuff. And like knowing like the standard workups for all of those things, that's going to help you the next day, because you're not going to be like trying to think on your toes. you'll already have reviewed it. You'll be confident in your answers. So that's a big thing to do the night before as well.
Yeah, absolutely. Um, and I know that we have like through Blueprint Prep Company, there is an organization, it's called CramFighter, which is a website that kind of can help if you feel like you're in the situation where you're just a little bit overwhelmed with scheduling. This is a really good way to do that. Obviously you can build your own schedule, but this one just kind of helps one keep you on track, hold you accountable. And if you miss something, if you go over, which inevitably will happen, it will kind of regenerate to create a new schedule for you while still incorporating those things. It kind of plans for you to fall behind, which is life. That's what life happens. So this is a really great resource for people if it's something that you feel like you could use the help with.
Especially if you're one of those people that isn't really good about like creating lists and tasks and calendars and breaking things up. CramFighter is just going to do all of that for you. So if you're one of those people that's not so good at it, this is a really valuable tool for you.
Yeah. Plus it feels kind of good to have like a checklist that you can like check off everything that you do. So
Yeah,
always
a little positive reinforcement.
but yeah, this is just kind of going over the different things that it can help you focus on. Um, and then, yeah, so there are obviously a wide variety of clinical rotations. You have your inpatient, you have your outpatients. So what do you expect? You know, like if you are going into a hospital medicine or a critical care or any situation where you may have inpatient rounding, what does that even mean? I know I went into it and I was like, they would say, "Oh, get there at like 7 and then we'll round by like 9:30." I'm like, "What does that mean?" You know? Um, so I worked overnights, but I did some clinical rotations in the morning and we would do all these roundings. And basically what you do for rounding is it kind of depends, but it'll be, you know, probably you, your preceptor, maybe your preceptor is attending, and you kind of go over these patients in a way that's very clear and concise. We're talking about what brought them in the first place. And if they're a new patient, you'll go through everything. If they're a known patient that you may have seen yesterday, or perhaps the practice saw yesterday, you kind of just talk about what was done yesterday, what results are showing this morning, and then what is the game plan for these people. So for you as a student, in the beginning, you might just be observing the rounds, but eventually they may give you a patient or two that you then get to present. And so what does that mean for you is obviously being prepared. You want to get there early and early as you need to get ready in time for rounds. You need to do the lab work. You need to kind of see what direction is this patient going. If you are not familiar with them and you need to kind of re-listen, reread all of their stories, see all their chart review, that may take longer. But if you already know the patient, you know, you can kind of time that out appropriately. But then it's the hardest part is figuring out, okay, what do we do next? What does this mean for us? You can have different kind of rounding that is just providers versus sometimes you'll have the providers and the nurse will be there. If the nurse isn't there, I would make sure when you're rounding in the morning, you go talk to that nurse and say, "Hey, any events overnight, anything happened that I should know about, any concerns that you have," because they're there with the patient. And sometimes you'll even get pharmacists involved depending on the site that you're at. So overall, you want to really familiar yourself with presenting patients and you want to know their history because you don't know what questions you're going to get asked. And oftentimes, you may find yourself in a situation where you don't know necessarily yet what's pertinent. So I would try to know most of it. And then if your attending asks you a question or your preceptor asks you a question and you don't know the answer, I'm sorry, I don't know that. Let me find out for you. Always make sure that you're ready to say, I don't know. Do you have anything with inpatient rounding, Logan? I know you work mostly outpatient. That's why I kind of talked about this one, but
Yeah, this is definitely your forte more than mine. But something that I always really struggled with. So I had patients at my old job, or students at my old job, not my current job. And a lot of times people don't want to say, I don't know. So they'll just start rambling. And that is absolutely the worst thing you can do because not only do you not know the answer, but now you're wasting their time too.
yeah,
So don't be that person that doesn't know the answer to the question. So they start like talking in circles around the topic. Everyone's okay if you say, I don't know. You don't have to know everything and nobody's expecting you to.
right.
So that is one thing. And then just with pre-rounding too, it depends on what site you're at and what hospital and how it works. But generally how it works for me, especially when I was on like my surgery rotation, which is where I feel like you do a lot more of the rounding, is that students round first, then residents, then fellows, then attendings. So if you talk to like the resident, so on my surgery rotation, my preceptor was a surgeon. So I would go through the resident and the fellow and him, which meant that I was really going to start rounding at, so let's say that he said he was rounding at 9. That means that the resident's rounding at 8, or the fellow's rounding at 8, the resident's rounding at 7. So you're rounding at 6. So you should be there, do everything first, because then you're going to re-round with the resident, re-round with the fellow, and then re-round with the attending. So that was how it generally worked for me. And I think a lot of places are like that. But also depends on like what service you're on and whatever. So asking whoever is available or other students, or if there's a resident or whatever, what the students generally do is going to be your best thing, because every site is different.
Yeah, I agree with that. It's always different. So my experiences won't be the same as your experiences.
Right.
But just like Logan was saying, the best thing to do is if you don't know, you don't know. Know that patient. If you only have one patient, know them like the back of your hand. Even if you have only two, like know that patient because it's just gonna look good. If you can say, "Oh, is this person a diabetic?" Yes, they are, or no, they're not. And what was their last H1C? Oh, it was this. That's how I know that they're a diabetic. Um, it just looks really good. But again, you're not going to ever know it all because you won't know the pertinent positives until you have the medicine down. So,
Yeah. And if they assign you a patient, you better know everything about them. A lot of things people don't know is their morning labs. So if you get assigned a patient that you have to present, make sure you know those labs like the back of your hand, and
mhm.
make sure you know them as compared to yesterday. So don't just say like CBC was normal. Say like their hemoglobin is up zero point 0.8 from yesterday. It's a good sign that, like whatever, they're recovering from surgery. So
Yeah.
making sure you notice not only what's normal, but what changed from the day before. That's a big
Yep.
one. And
Yeah.
what they're scheduled for that day. If it's PT, if it's OT, if it's an MRI, whatever, knowing what they're scheduled for that day, what's going on.
Yep. And another thing too is if you're rounding, make sure you're seeing the patient. You're not just looking at a chart. Like you're not just getting there and reading it. Like go in and talk to that patient. If you can, do a physical exam. Uh, what pertinent findings do you have? Like, hey, just want to draw to your attention. Their belly felt a little bit distended this morning to me. Let me know what you think. Um, that kind of stuff. So,
Yeah, and making sure whenever you're with the resident or the fellow too, if that is an option, um, doing dressing changes, cleaning wounds up, things like that. You shouldn't be doing that on your own, but when you're with somebody, then that's something that's always really nice and helpful for you to do. Is that, like you say, we changed the dressing this morning, we checked, there's no discharge, there's nothing, everything's healed nicely, no dehiscence, whatever.
yep. All right. All right, Logan, take it away.
All right, outpatient rounding. So this is my forte. A lot of times this is a lot less intense, a lot less specific. So more or less you're just presenting a patient. Um, you want to always make sure that everybody's a little bit different in how they practice medicine and what they want when they want a presentation. So the first thing I always did on my clinical sites is that if I was asked to present a patient, I would say, okay, what do you want in your patient presentation? So in my clinic, I do primary care. Don't tell me that my patient is like a 48-year-old male. I already know. I've been seeing him for 5 years. So something I'm like just say, what are the new updates and any acute complaints today? Have they been seen by their specialists and when? So that would be a typical like primary care, just like continuation of care follow up. Or if we're doing like a physical exam or like a full annual physical, then I want to know like vaccines and colonoscopy and like health maintenance stuff. So you have to adjust based on what setting you're in and what your preceptor wants. So just ask them beforehand.
Yeah.
Um, make sure that you know how to do a physical, how to do an interview, and you're not going too far in depth. Again, if you're in a primary care clinic and you're outpatient, don't do things that are already in the chart. So family history is already there. Don't ask anything besides, is there anything new? So all that kind of stuff of just knowing how you do everything correctly and then knowing how you can focus it into whatever specialty you're supposed to do. So you're mostly doing focused exams in outpatient. You're not really doing full comprehensive exams as these are known patients. So that's the kind of thing. And then making sure that you're being mindful of the time. So a lot of times you'll send a student in a room and you kind of have to go get them 20 minutes later because it's been 20 minutes and that's way too long that they should have been in there. So checking in, making sure that you're trying to be efficient with, and you're not cutting the patient off. They're making sure they're feeling heard and all of that kind of stuff. And you should be fine. Know their vitals, know what they're there for that day, and have like a assessment and plan that you thought about. Just make sure you're not presenting plan to the patient yet.
Yes, I agree, because it could always change, right? Like, you're a student. Yeah. All right. Okay, so the physical. So I think it's important, and they're saying that here, there's not just one way to do it. Everyone is going to do it differently. You can put me and Logan in a room for the same complaint on the same patient, and we will do different things. I mean, we'll do mostly the same, but like some different. And the best way to kind of like organize your thoughts is, as a student, kind of watch people, watch what they do, and have your own idea of what you should do, modify it based off of what you learn. And right now, I do about the same thing on every single patient, unless there's a specific complaint. Just make sure I'm hitting all of the points that I need to focus on.
Yeah. A few things students really commonly forget is washing their hands. So just do it as soon as you walk in the room. That's normally the easiest. You won't forget it. Walk in the room, wash your hands, sit down, and like while you're introducing yourself, and then sit down and talk to them. Make sure you're making eye contact. You're not trying to write everything down. You're not trying to be on the computer. Sometimes it's necessary that you're on the computer, but you just want to make sure you're switching at least 50-50 with eye contact versus computer or note time. And like Olivia said, everyone does things differently. I prefer, most people prefer a head to toe look. So when you do your physical, you start at the top and go to the bottom. I definitely don't do it head to toe anymore because I am like a heart and lungs first, then to head and toe kind of person. So everyone will get the same thing out of it. Just make sure that whatever way you're doing it, you're going to do it in a way that is succinct and makes sense to you, because you don't want to forget anything. And if you do forget something, just say, I forgot to ask that. I forgot to do that. Don't make something up, because they're going to go in the room, they're going to find out, and then you're going to be in trouble.
Or even worse, they will trust your judgment because you've been with them for 3 weeks, and then it'll get missed. So we cannot be making things up. Yeah.
Yeah.
If you forgot to listen to their lungs, I don't care. Like, that's embarrassing, because it's like we always listen to heart and lungs, but just take it as a, oh my gosh, I didn't listen to their lungs. Don't say, nope, normal lung sounds.
Yeah.
Don't ever. And that'll make you look really bad if you never know what then your preceptor is going to hear. So
Exactly. Another thing with making sure like the physical exam is focused, don't be doing some crazy testing. If they don't have carpal tunnel complaints, don't do it now. If
yeah,
they're,
for real. That's funny.
yeah, sometimes people would come back and they're like negative Homan, and I was like, why are we doing a Homan sign on a patient that's here for a physical? Are they complaining of, like, are you worried about a blood clot? Then don't do that.
Yeah.
So making sure the things that you are doing are purposeful. So you're ruling out things that you need to rule out, and you're ruling in things you need to rule in, and you're not doing anything outside of those things. There's a few, obviously, like above and beyond things, but you don't have to be worrying about doing those all the time.
Yep. Okay, so particularly relevant to outpatient visits.
Making sure those people have their medication list. If they don't have their medication list, a lot of times they'll have pictures on their phone, anything like that. A lot of patients don't know their medications, don't know their dosages, whatever. So you should be.
Sorry about that.
No, you're good. It's always better to talk in generic, but when you're talking about things like Trulicity and Ozempic and just like very new branded medications, HIV regimens, all that stuff is branded. So speak in the language that the patient is speaking in. If they say, I'm taking Biktarvy, you're not going to break down Biktarvy into its 3 antiretroviral components and say it like that. So they say Trulicity, you say Trulicity back. If they say semaglutide, you say semaglutide. You don't want to confuse them any more than they already are. Confirm their names, their strengths, their dosages. If you can't do that, just ask them for their pharmacy's name. You can easily call the pharmacist and get their full list. I do that all the time. not as much at my current job, but I used to be at a geriatrician office, and that was constant. Patients didn't know their medications. They didn't know. They're like, oh, my cardiologist changed something. It was something that started with a C and it went from 12 to 50. And so like a lot of that stuff is very common. You can always confirm with a pharmacist. It takes 5 minutes and it's gonna make you look really good for your preceptor. So if they're off doing something else, quick call to the pharmacy, grab the medication list, and then go in with it.
Yeah, that's actually an excellent point. Like if you are the one as a student who says, "Hey, yeah, I called the pharmacy," they're gonna be like, "What? That's awesome. Good for you." That's
Yeah,
yeah, gold star.
yeah. And then something I always ask patients too, and I think it's good when the students do, is that before you leave the room, is there anything else you wanted to talk about today? Do you have any other issues, comments, concerns that you wanted to talk about today? That makes sure the patient is feeling well heard and they're leaving with everything completely out there on the table and that you can manage it all. So that's an important one that I think people can tend to forget. Don't laser
Yeah.
focus. Even if they're just there for a UTI, see if they got their flu shot, see if they got their COVID booster. Do they need a shingles vaccine? You know, it takes 2 seconds to look at immunizations. It takes 2 seconds to look at what they were there before for, and just popping that into your notes. So, oh, I see you were here for a sinus infection a few weeks ago. Did that clear up? Did you have any side effects with the medication? Those things take 2 seconds to do, and it really shows the patient that you're looking.
Yeah, and it helps you in the future, like, yeah, actually my belly kind of hurt when I took amoxicillin. All right, good to know.
Yeah.
So, all right. And then this is just kind of saying to try, just like Logan was saying, to avoid just like staring at the computer. And
Yeah.
also,
And
oh, go ahead.
no, I would say, and putting that erroneous data in there. So if you're copying and pasting labs, don't do that. Copy, if you can copy and paste it from somewhere else, then you don't need to be putting it in your note. They can easily go find it. Everyone knows how to use the EMR just as well as you do. So don't be copying and pasting erroneous stuff in.
Yeah, absolutely. So this is kind of back on like the inpatient rounding, so I won't go too much back into this right now. But inpatient rounding, inpatient, the internal medicine rotation from an inpatient setting is a lot different than outpatient. And sometimes you'll be on an internal medicine rotation with a PCP group that will also round in the hospital. So it's nice, it's a wide variety. But then they're seeing their own patients in the hospital. So it does give you a lot of responsibility as far as like where to focus in that rotation. And so it's kind of combining the two things that we just talked about. And the hospital is going to be a little bit more usually like critical situations, as far as less maintenance. And, if your patient is coming in to the hospital with a blood clot, maybe at that point, we're not talking about like our basic maintenance. We're focusing on those like acute issues at that point. And then they'll follow up with you in the office. You may very well see someone your first week inpatient, and then the next week see them as outpatient. So just kind of making sure that we are knowing what to do when, and knowing when to focus on the maintenance things. Even if this person is technically a PCP patient, if you're in the hospital, we want to focus on that. Anything to add for you, Logan?
Um, no, I think that's everything. And then just keeping in mind that when somebody is inpatient, kind of going off what you said, you're not handling those health maintenance things. It is what's going on that you can't be at home. How are we going to get you home?
Mm-hmm.
So the goal of inpatient care is getting them to outpatient, and that's really, really important. You don't want to waste time on things that will be managed outpatient.
Yeah, absolutely. And then family medicine, that's what you
This is me too.
do.
So family medicine's a hard one because it's broad. So you're seeing everything from peds to pregnancy to adult care and medicine. So this is one that if you have later on in your rotations, it's going to be really helpful for you if you've already done like IM and peds. But if you haven't done those things, making sure that you at least have a basic understanding of your peds and your women's health going into this rotation, because those are the ones that people forget. They're thinking family medicine, primary care. They're thinking a generalized adult population, but you also have to have your women's health and your peds added on there.
Yeah.
A lot of family medicine is routine physicals, routine follow-up, and like acute sick visits, like almost like an urgent care. So making sure that you know those most common health screenings, so things like colonoscopy and vaccines and all that kind of stuff, but also how to treat general acuity things. So UTIs are based on local resistance, so you want to make sure you know your local antibiogram, and knowing what you commonly use, all that kind of stuff. If you're going in flu season, you're going to be asking about flu vaccines, and then knowing what kind of testing your site has. A lot of family medicine places will have rapid COVID, rapid strep, rapid flu. So knowing if those are services that are offered by you and if you can do those is going to be really helpful for these rotations.
Yeah.
Trying to think of a few other things. But that's pretty much everything. A lot of things you're going to be talking about here are nutrition, disease management over a lifetime, lifestyle changes, smoking cessation, all that kind of stuff. So make sure you have all that kind of in the back of your head. I think it's easy for people to forget that people do still smoke cigarettes. So keep in mind that smoking cessation, you have to know like about Chantix and the side effects and what that kind of looks like and all of that. So don't forget about those little details because those are really important too.
Yeah, they can save
Um,
someone's life, really. Like if no one's told them, then now it's time.
yeah, you'd be surprised how many people document smoking cessation discussed, and not a single time has anyone ever discussed Chantix with the patient, and then the patient ends up saying yes when you bring up Chantix. So making sure you're not skipping over those things. A lot of people that smoke do want to quit smoking, and they just need help doing so.
Yep, absolutely.
All right,
Um,
Olivia, this is you.
So surgery rotations, they can often be kind of overwhelming for students. I know I was a little overwhelmed when I went into my surgery rotation. As I said, I work in surgery right now. And I think the big things as far as for students is it's hard not to feel like you're in the way in an OR. And sometimes you are in the way in an OR. And I think it's important to realize that to kind of try to figure out where I should stand. Your absolute best friend is going to probably be the charge nurse or like the circulating nurse in the OR. They know where you can stand. They are usually not sterile, meaning that you can ask them questions if you have to. You don't want to distract them, but you can say, hey, where's a good place for me to stand? I'm here to watch the surgery. You may or may not be scrubbing in, and that's something for you to discuss with your preceptor. But overall, really familiarize yourself with the staff and familiarize yourself with where you get your gown, where you get your gloves, and where should I put them. So I know that there's more on the next line,
Make sure
but
you know your glove size too.
yeah,
A lot of patients go in, they say medium. You don't want to be that. You don't want to be that student that said medium when they ask you your glove size.
literally. And honestly, like when you walk into the OR as a student, first off, it's usually a very niche area. So people are going to know that you're like not usually there. So you want to say like, hi, I'm Olivia. I'm a physician assistant student. I'm working with blank, like who's your preceptor? And just say, you know, I am coming here to watch this, or I'm going to be scrubbing in. If you don't know, then just say I may or may not scrub in. Always have your stuff in case. The Either the scrub nurse or surgical tech, whoever it is, will have a very clear sterile field. And what you need to do is never put anything on the sterile field, even if you open the gloves and just drop them on. Do not do that without talking to them. Most of the time, they'll prefer just to take it out of your hand. The You will contaminate yourself when you are a student. It is almost expected. You're going to need to practice gowning and gloving, all that kind of stuff. And there'll be a situation where maybe you just walk too close to someone or you bump something. It happens to the best of us. But what you should never do is contaminate their sterile fields. That's a problem. So make sure that you're knowing what's sterile and making sure that you're asking for help if you need help in those situations. Do not assume that they're going to get your gown and gloves for you because they probably won't. And it honestly just kind of makes you look entitled. Like you want to make sure that you are that you're getting that for yourself. And you also want to make sure that you are in there when that case starts. I am helping to transfer the patient. Hey, do you want me to put the Foley in if you need one for that case? Or hey, can you show me? I'd like to watch. Anything that you can do to make their lives easier. If you're on par with the OR staff, you will have an excellent rotation. That is just the way it works. So
Yeah. The only thing I would add to that is not only don't contaminate the sterile field, but if you are not scrubbed into that surgery, you got to be at least 6 to 8 inches away from it.
Yeah.
So don't get right up on it. You're gonna make everybody in the room nervous. They don't know you. They don't trust you. So make sure you're keeping an appropriate distance, asking, is this an okay place for me to stand? Where would you like me? X, Y, and Z. That's going to be really beneficial for you. And if somebody says you contaminated it, don't fight back.
Yes, that's a great point. Like, no, I didn't. No, you did. So just, yeah.
You did. And even if you didn't, now everyone's unsure. So we're going to do it. We're going to act like you did anyway.
Yes,
So
100%.
one thing that they taught us, so anytime you're scrubbed in, hands just right here, hold them right there. If you're not doing something with your hands, put them back right here. That's where the easiest way you're not going to contaminate yourself is just hold them right in your sterile field, making sure that, you're going to drop your hands if you don't have them in an appropriate spot. So either they go on the patient in the sterile field or they're in front of you touching each other. That's the easiest way to not contaminate it.
Yeah, that's an excellent point. I honestly still do that aimlessly. I'll just be like this if I'm not using my hands when I'm scrubbed in.
Yeah.
And then, always make sure that you've like gone to the bathroom before a case starts. If you can, try to eat. You don't want to be passing out in the OR. Do your best to like make sure that you're not going to be able to access these things for an X amount of time. Even if you're not scrubbed in, it's really rude to walk in and out of the room, and it's a contamination risk. Every time you open that door, you're kind of like opening and there's airflow, just a little bit, but you should really just try to keep it shut. And so don't walk in and out of the room unless you really have to. That's probably all on that I can say right now. So typically the OR is obviously sterile or not sterile. The sterile field is going to be where the patient is, okay? And then it's going to be usually a desk type of thing with a whole bunch of equipment, and that's all going to be sterile. That's where the scrub tech or the scrub nurse is, with all the instruments and stuff that you need to use. So when I'm talking about like dropping your gloves, sometimes you'll see on that table a bunch of gloves, but you don't want to drop your gloves, because if you take your gloves and you drop them the wrong way and it's not sterile, or if someone didn't see you do it so they can't confirm, like the student didn't, not sure if it's sterile, all of that stuff can be considered contaminated. That's a very big deal. So the patient will eventually be sterile once they do all the prep work. Anesthesia will be at the head of the bed, usually behind kind of like a drape, and they are not sterile. So, and you can kind of tell what providers are sterile because they'll be gowned and gloved. So if you are sterile, stand by the sterile people. If you are not sterile, stand away from them. Yeah, so just this is kind of what we were saying, just make sure you're paying attention. You don't want to touch your face. You can't really touch anything. You kind of have this little box right here. We always say like right above like mid chest to like right below the diaphragm is kind of your little square here that you're sterile. You don't want to put your hands too low, nothing behind your back. Anything you can't see is not sterile.
Yeah.
So and then women's health.
Yeah, so women's health is another one that encompasses a lot. So you're going to find your days are very different here. Some days you're going to be doing like outpatient, just clinic days. Some days you're going to have to do deliveries, some days C-section, some days inpatient surgeries and stuff. So just be ready to basically do anything. Making sure you're reviewing all of the stuff you're not using in your other rotations. So like the milestones and at what week, what testing you're doing, what weeks you're doing the vaccines and Rogan if you need to. All that kind of stuff is really important stuff to go over before you get there. The other thing that is always different is PAP and HPV testing. So knowing what the results are. I honestly, there's ACOG and then there's USPSTF, and they both have different recommendations for when you're doing PAPs and what you're doing based on the results. I kept those printed out and in my pocket because I looked at them at least 10 times a day.
Yeah, literally, yeah.
Yeah. Knowing how to do workups for the most common stuff. So STIs, UTIs, abnormal uterine bleeding, all those kinds of things you're absolutely going to see. So knowing what labs to order, what tests you do, in what orders, and like the same thing with your PAP follow-up. So when you're doing a LEAP, when you're doing a PEEP, when you're doing biopsies, all that kind of stuff.
And then, outpatient women's health is probably going to be one of those sites where you may see more so than other sites that patients may not be amenable to students. And so I think I would just prepare yourself to that for that. It has nothing to do with you. Obviously, 99% of the time they don't know who you are before. If you are a male student or a student that identifies as a male, that may be a situation that you might come across more often. And that's just because, it's a very sensitive exam. I mean, I know when I first went to the gynecologist, if they would have asked me if I had a student, I would have been like, oh, I don't know. I'm what, 19 years old. I'm a little bit shy. I don't know if I'm really wanting to have a student. Or if you have a patient that may be coming in to talk about something sensitive, they may not be always amenable to a student. If you do go to a women's health rotation and they are amendable and you find yourself in a situation where it is a very sensitive topic, make sure that you are ready to be a very good listener, and also you have to kind of have be ready to hear about these things. You don't know what you're going to encounter. It could be anything from, STIs to non-consensual sex that they may be discussing. And I think it's something that most students, especially without being experienced, may not be ready to hear. But obviously it's probably harder on the patient having to discuss it than it is on you listening to it. So you just want to make sure that you are a good listener, especially if you're in there by yourself and your preceptor is not there. You are the person that they are kind of leaning on and relying to right there, and it's a huge honor for them to want to open up to you. So just be ready for that.
Yeah, really being sure. It's a lot easier now. I feel like most places are still wearing masks. I live in New York City, so we're very masked, but it's easier with the mask, but still making sure you're not making any weird faces, you're not raising your eyebrows. All of that body language is really, really important when you're talking about sensitive topics like this. So if somebody's talking about rape, or if somebody's talking about STIs or being cheated on or whatever, that's something that comes up a lot in women's health. Making sure that you're not making any faces, you're empathizing with the patient, all that kind of thing. So it's a sensitive thing. So you want to make sure that you are on top of what you look like and knowing what you look like in those moments too.
Yeah, excellent.
As a male student in women's health, I definitely did get turned down a lot for going into the room. So that's a rotation that's really, really important to bring an activity like studying materials and that kind of stuff, because you're going to find you're sitting outside a lot.
Yeah. And so use that time to study and, okay, what's their chief complaint? Even it could just be like a regular maintenance exam and they just may not want a male in there, which it's whatever their preference is. Sometimes it helps if you have a male preceptor in women's health, because then they're expecting a male anyway. So
yeah.
And then the ER. You've never worked in an ER like outside of your clinicals, right?
Mm-mm.
Yeah, I didn't work in the ER. I had obviously a lot of contact with the ER as a hospitalist. But overall, just like the emergency room is a very fast-paced situation. And so just like in an outpatient setting, you really just want to make sure that you're not slowing people down. And it's going to depend on what the preceptor is wanting from you. But I would definitely use the whole trying to get to know everybody, support staff, other providers, because you can learn a lot in an ER, but it's just like the luck of the draw. Who comes in the room? Who are you seeing? If you are a student and your preceptor is not seeing the patient that needs sutures, but you have a good relationship with another provider, maybe they'll say, hey, you want to come and suture? Let's do it. So I would definitely use that. I would definitely be very knowledgeable about the big emergency situations. For ACLS, you may very well see it. You're probably not going to be too involved. You'll probably be kind of like a fly on the wall. But in those situations, one, if they ask you to do compressions, be ready to do good compressions, know what steps to do. And if you are a fly on the wall in this situation, try to be predicting what the provider is going to say. What do you think? What would you do with that rhythm? Or what would you do next? It's a very, very scary but great learning opportunity if you do come across them. And so you want to make sure that don't be shocked into just try to be thinking one step ahead, which is obviously easier said than done, which is why we do rotations. So
yeah, I think that ER is one of your really important rotations because it's where you're going to get a lot of procedural experience. So making sure you're always throwing yourself in there to say like, can I do these sutures? I've done sutures X, Y, and Z times before. I've done this, I've done this, I've done this. Always volunteering to do any procedures that are coming up. And if you notice that somebody else, so my ER rotation, there was a whole bunch of students. So we kind of like would grab each other when we were going to do something cool. So if people are doing like conscious sedation and like popping shoulders or hips back in place, that's something where, you know, if somebody else grabs, you can say to your preceptor, hey, actually over in room 4, they're doing conscious sedation. Would you mind if I popped over there and watched it? You're just going to go see another UTI.
Yeah.
So making sure you're asking, saying like, this opportunity popped up, this opportunity popped up. One thing that happened to me, it's definitely not common, but in the ER I worked at, it was a very rural ER, and they were kind of very honest as the students. They were having us run ACLS.
Oh,
Um,
wow.
yeah, so make sure you're ready to do things like
Yeah.
that. I don't think that's a very common thing to do, but they'll like have the patient on the table and be like, okay, what's the next step? Student, go.
Yeah.
Um, so
So
be ready
then
for that. You never know
you
if you're going to
ready.
get one of those crazy preceptors that's like that. They're like, quick, time to pimp right now. The patient's coding. What do you do? What's the next step? What's the next step? What's the next step?
Yeah.
So that's, and a lot of times, even once they stabilize the patient too, they'll ask you, they're like, okay, so if that didn't work, what would you have done? Then what would you have done? Who should you call? What should we do next? So sometimes that can be like those stressful situations where they want to pimp you a little bit more.
Yeah, and that's why it's always good to like predict the next step, because then if for some reason they say like, "Hey, Liv, what are you doing?" then you can say, "This is what I would do," because you were already thinking about it. You were already thinking about that next step.
And if you're in a code room, make sure you're looking around what's around you. Make sure you know like where the tubes are, where like if you think you're gonna have to intubate, because a lot of times any person's hands in that room are really helpful. You want to know where things are that you can quickly grab. I would always say have gloves on you because you never know if you're gonna have to dive in, um, and all that.
Yeah.
Outside of a code setting, I think the most important thing for ER is your ability to triage. So seeing what patient can wait, what patient can't wait, and ruling out the most important and life-threatening things first. Um, so ER is defensive medicine.
Yeah.
So in primary care, people are coming in, you're thinking the most common things and ruling out other things, you know, later. If somebody's in the ER, this is why a lot of times in the ER you order extra labs, you do extra imaging and all that kind of stuff. You're practicing defensive medicine. So you're making sure that the biggest thing, most urgent, most life-threatening thing is absolutely not happening. And then you can go down to the more common thing. But you're kind of going to have to flip the way you think versus more common, it's definitely not this, versus let's make sure it's not that, then bring it down to most common.
Yep. You have all the resources available to do the scans if you need to. You want to know what kind of labs you should order for these patients, and just everything that Logan was saying as far as like getting your foot in the door and making sure that you are available and eager to do all the procedures, because that's where you're going to get most of them.
Yeah. And I don't know if it was like this for you, but for me, the ER was definitely one where I had a lot of freedom. So be ready for that.
Yeah, and I think it just depends. Like it totally depends
Mhm.
on where your site was. I did, but for some reason, emergency medicine was first for me, so it was kind of a whirlwind.
Ooh,
I know it was
yeah.
the way that the world worked for me, but yeah. But this is just exactly what we were saying. Like if someone comes in with a headache, this is just what Logan was saying. We're ruling out the big scary things, okay? And then if once we get not all patients will need a CT scan, but you need to kind of look at the clinical picture and you have to decide if they do or not. We're not just
Yeah.
ordering things to order tests because they're expensive. They cost these people money. But if there's any signs of like any neurologic problems or anyone ever says this is the worst headache of my life, like you're probably going to get a CT scan, because we're ruling out these scary hemorrhages and stuff like that.
Yeah. One thing to be mindful of too is there's lots of criteria for when you do CTs and when you don't. So if you think about things like the PERC rule or even for x-rays, is it like the Ohio ankle x-ray that you're
Yeah,
talking
some kind
about?
of index or something like that. Those are
Yeah.
all really
So
good things to have with you printed up.
yeah, making sure you're aware of when are you going to order an ECT or an X-ray and when are you not, and have a reason for why. So
Yeah.
lots of people come in with abdominal pain. Not everyone needs an abdominal CT, and if they do need one, you need to know whether it's with, without, or with and without.
Yes.
So what is your differential? What do you need to diagnose those things?
Yeah.
That's going to be a big part of it. You know, people think like, okay, get a CT. They're like, okay, CT abdomen, CT pelvis, CT abdomen
Yeah.
and pelvis, with contrast, without contrast, with and without. Has the patient eaten? Are they allergic? All these things that you need to, if you're ready for when they ask you those questions, you're going to look really good.
Yeah.
Versus somebody that just comes back and says, I think we should order a CBC, a comp, and a abdominal ultrasound or
Yeah.
CT. Like you have to
Yeah.
figure out why you're ordering those things. What are you looking for, and what's your differential? You should walk out of every room and figure out what your differential is from most common to least common.
Yep. Sometimes people will have like these like catchphrases that they say, or like those phrases that make you think of certain things, like worst headache of your life makes you think of a subarachnoid hemorrhage. When I was on my ER rotation, it was like my second day. I was in a room with a patient and they were like, it just feels like an elephant's on my chest. And I don't know why I did this, but I was so scared that I walked out of the room. I said, I'll be right back. I walked out, I went to my preceptor. I said, this person said that. And she's like, okay, and I was like, well, what if they're having a heart attack? It ended up being a COPD exacerbation. So I think it's just being like also mindful too, because people say whatever they are thinking and whatever they feel. And even that's not like always going to be textbook. But I just remember being so freaked out that I literally left mid-exam. I was like, I'll be right back. And I went to go get her. And I wish I didn't do it, but you're a student. It is what it is. So
Yeah, on the contrast, I did that in an outpatient setting, and I was like, this woman's having a PE, and she actually did have a PE.
so
So
you can never be too careful.
yeah, sometimes you have to trust your instinct. But another thing you'll notice in the ER is when you ask patients the 0 to 10 pain scale, making sure you're saying 0, I feel no pain at all. 10, the worst thing I could possibly imagine. If
Yeah.
they're sitting and having a conversation like this and saying that they are an 8 out of 10 pain, you're gonna have to go over those guidelines with them.
Yeah.
So
And
if they're like, yeah, I would say my pain is about 9 out of 10, and they're saying it like that, it's not 9 out of 10 pain. So you're gonna say, okay, 9 out of 10 pain is like pretty unbearable. Are you sure it's that, or do you think it's more do you think it's more of like a dull ache? So
yes.
my questions are, if someone tells me they're in pain, I say dull and achy, sharp and stabbing, or numb and tingling.
Hmm.
And that's a good way to like differentiate what you're looking for versus like nerve, muscle, whatever else.
Yeah. And if they say, my stomach hurts, okay, where? And then they're like, oh, just kind of below my ribs. Will you point to it for me? Will you point to where it hurts? Like, let me see where it hurts. Because everyone's like kind of, I mean, they could literally say left and mean right. Just have them point to where they're talking about.
Yeah, and keep in mind that patients don't know anatomy like we know anatomy. So I had a patient come in complaining of sternum pain last week. His sternum pain was all the way down here. So I had a female patient come in that convinced that she had prostate cancer. So, you can't,
That would be a first. Yeah.
yeah. So having people point to where the pain is a really good thing, because they say they're having pain in their stomach and it's actually like bladder or something like that.
Yeah.
So localizing it down, because they think that their stomach is their whole abdomen, and that is obviously not the case.
And like, kind of what Logan was saying, this is a big triage. And we need to know, is this person going home or are they staying in the hospital? Okay. So we're ruling out emergencies. And then once, if we rule out any like emergencies, we have to say, is this person okay to go home or is this patient needing to stay in? There's a lot of different resources that you can use for this. Off the top of my head, you can use different scales to identify if someone with pneumonia can go home. These are all great resources to either have printed or to have. A lot of them are on MedCalc. So just to have written down so you know what to look up. That way you can present this to your preceptor and say, hey, because this person has pneumonia, I did her risk scores. I think she should stay in the hospital. They're going to say, that's great. That's what I was thinking. And, then you're practicing like you're a clinician, which is the whole goal of clinical rotations.
Exactly. 100% agree. Psych. So Olivia, I worked in psych before PA school. I haven't done that as a
Oh,
PA, but I can take the lead on this one if you
yeah,
want.
please do. Absolutely. I had 4 weeks in psych. That was it for me. So.
All right. So I was a mental health tech before PA school. I worked in a year in the acute care psych hospital. Um, People are afraid of psych. They always are. PA students, med students, NP students, everyone's afraid to go into their psych rotations. Psych is not scary. And I think that's the biggest thing people have to learn about psych is it's okay to talk about these things, it's okay to talk about wanting to kill yourself but not knowing it and all that kind of thing. These patients that are coming to these practices are used to this. So it's going to be uncomfortable for you. It's not uncomfortable for the patient though, so don't make it uncomfortable for the patient. Um, the first thing about psych is you never know what kind of patients you're going to be seeing. So in my psych rotation in PA school, I was actually at an eating disorder clinic. So it was a very niche aspect. Some people go into outpatient clinics, some people go into inpatient clinics. The variety of patient you're seeing is dependent on what kind of setting you're in and what your location is. So first, you want to figure out what your preceptor is typically seeing, what are their 5 most common diagnoses. If they're seeing a lot of like personality disorders versus a lot of like anxiety, depression versus a lot of psychosis. Those are really important things to differentiate because all of those treatment plans are different. And the way you're talking to those patients is different too. The most important thing about psych is the HPI, HPI, HPI. So how do you feel? What's going on? When was the last time your medications were changed? How do you feel on your medications? Are you having any side effects? What are you doing to cope with those side effects? Are you in therapy? Is there substances involved? All that kind of stuff. There's so many layers to psych and it's so cerebral. It's not something that's going to be so straightforward as labs and imaging. It's just very, very person dependent, HPI, how do you feel? So it's a lot more talking and a lot less labs. And I think that makes people uncomfortable because there's not a good black and white. Know your DSM-5, know your diagnosis criteria. So obviously you don't have to have it memorized, but you can pull those things up on your phone. And if they have to hit 7 out of 10 and they're only hitting 6, then they're not at that diagnosis, and that's an important thing to do.
Yeah.
Sometimes you kind of have to work in psych with patients who aren't really health literate. They don't know how to explain what they're feeling, and you have to be ready for that. So bringing it down to whatever education level they're at, it really helps you have peds before this. Sometimes you're going to have to talk to them like they're younger than they actually are because of whatever their development level is, or sometimes whatever medication they're on. If they're taking Thorazine 3 times a day, they're going to be zonked out a little bit. And you kind of have to deal with that.
Right.
So a lot of psych is knowing what the diagnosis criteria is, what screening tools are you using, PHQ-9, are you diagnosing ADHD, what are you using to make all of those assessments, autism scales, all that kind of stuff. So a lot of it is making sure you're prepared when you go in the room and you know what questions to ask. Don't be uncomfortable. The question you're going to ask almost every psych patient is, do you have any thoughts of hurting yourself or others? You should be practicing that in the mirror before your psych rotation because it's a very uncomfortable question to ask. And when a patient says yes, that's even more uncomfortable. And you have to be able to make sure that you're not uncomfortable in that situation. You're not showing that you're uncomfortable.
Mm-hmm.
Psych, you have to think about safety a lot as well. So one of the biggest things with psych is the patient is never between you and the exit. Keeping that really, really closely in mind of knowing your escape route, knowing what you have on you. You don't want to wear your stethoscope around your neck in psych. You can get choked with it. Things like that. So just adjusting a little bit. So you're knowing that your safety is in check, but also trying not to be scared of those patients. So walking that borderline there.
Yeah, I think that's really important. And then, I guess we're at the point where we've kind of covered the specialties and we can talk about like what not to do on rotations, which I think we kind of stepped on all of these at least once. But, again, with the making sure that with patients, if they say, I don't want a student, no problem, or thank you for your time, no problem. Never argue with your preceptor. You would think that has never happened before because why would you do that? But it has. And I would just definitely, I would not advise that. Make sure that, go ahead.
On that note, I think it does happen a lot and it's crazy that people do it.
Yeah.
But if your preceptor develops a plan, they have developed a plan, you can say, hey, I was thinking about doing this. Why did you do that instead? That's an appropriate way to ask the question. You want to do that when you are very far away from the patient, not in earshot, and you're making sure you're doing it in that way. I've had patients try to correct me in front of, I've had students try to correct me in front of patients. And I think it's the most frustrating thing because it's not that it's really sowing doubt with the patient, but now you have to explain not only to the student in technical terms, but to the patient in layman's terms of why you made the plan that you made.
Yeah.
That's something that's really frustrating that nobody wants to deal with.
Yeah.
So
And I think it's
make sure you're
important.
not one of those people. Exactly.
Yes, yes. And like you said, Logan, like ask questions, but just not in front of the patient and ask them in a respectful way, saying, hey, like you said, why did you do this? I was
Why
confused
did you do
about
this
it.
instead of that?
Yeah.
Easy, easy not like I would have done this. Well, you wouldn't have done anything because you're a student, not a
Yes.
provider.
Actually, that would have been
So
illegal. So absolutely.
yeah, like that. I had I had students at my old job, and I think that was something that came up that said I would have done this, and I'm like, okay, you shouldn't have done that because you didn't see this allergy, or you didn't see that they're on this medication and actually interacts with that, or like X, Y, and Z. So you're probably, if you try to correct them, you're probably going to get proven wrong.
Yeah.
99% chance that you're wrong. If you think that there's a save you need to make, if you saw an allergy or if you saw a medication that you know 100% interacts, just say, again, away from the patient, say, hey, doesn't this have an interaction with that? Or, like, why did you do that given this? It's, you can always phrase it like a question and not like you're trying to correct someone. Everyone does make mistakes for sure, but the odds of a student catching a mistake are much, much lower than a provider making one.
Yes. And exactly. And there's a respectful way to do everything. And if for some reason you do say, like, hey, I thought that person had a sulfa allergy, like I saw that, I saw that we did Bactrim. Was there a reason that that you did that? The preceptor very well maybe like, oh, you know what? Because oftentimes when you put orders in, allergies will pop up on these EMRs, or like sometimes preceptors will have it where they'll like pick a medicine, they may say it out loud, and then they'll go in and they'll look and they'll be reminded, like, hey, there's a
Yeah.
sulfur allergy, it's big and highlighted. They will probably notice. But if you say it respectfully, they'll just say, hey, like, thanks, yeah, that's a good thing that you saw. I'll change it, and this is what I'm going to change it to. So
Yeah.
I also think like overstepping in general, there's so many ways to overstep on clinical rotations. I think one thing to remember is that while most people will know you're a student, not everybody will. So do not do things outside of your abilities. Don't do things unsupervised. If there is a code situation, don't step up at the front of the bed like you're going to be intubating or anything like that, unless you are asked to by someone who is very well aware that you are a student and your preceptor who you are working under. Um, it's wrong, it's not safe, it can lead to just like bad things, and you get really in trouble for that, and you can cause some safety issues, so don't do that.
Yeah. And the big thing about you, you are in these settings and you're working with these people every day, but don't mistake yourself for an employee. And that kind of goes into like the don't make fun of patients, team members, or staff. So, you're around these people all day, every day for 4 to 6 weeks. It's very easy to get comfortable and forget that you're, kind of a guest in that space. Even if other people are making fun of somebody, if they're talking about something, probably just don't join in on that conversation.
Yeah.
Certainly don't initiate it, but probably don't join in either. It's just not your place. You're a student, you're kind of a guest in that space. Just be mindful of that. Even, in those times where it feels like, this is a really cool office, I'm really like getting along with my preceptor really well. They're still your preceptor, you're still a student. Don't
Yes.
forget about that.
And then also, like we were talking about, we're not lying. If we don't know something, we're saying we don't know it. If we forgot to ask if the patient smokes, forgot to ask if they drink, we go back in and we say, like, well, if your preceptor asks, you say, I forgot to ask that, I can go back in. And then maybe they'll say, nope, I already asked. Or they'll say, yeah, why don't you do that? And then you can go back in and ask. Don't say a patient doesn't drink, because don't say they don't do anything. It opens a whole door of possibilities. And we already kind of talked about that. I think the only other big thing to really mention here is that phone etiquette. So you want to make sure that we're saying all these apps and resources on your phone, and they're great. But if you're using them, I would even just say, hey, I'm going to look this up on MedCalc really quick. Just make sure your preceptor knows, like, that's what you're doing. And if you're not doing anything resourceful, just don't be on your phone.
Yeah, I think that overall, you should model after their behavior. So if they're like really into looking stuff up on their phone, then you should do that too. But if they're like kind of old school and they don't like phones around, even if you are going to look something up on your phone, you should probably either say it first or say like, hey, is it okay if I use like I have like a few apps on my phone that I use to look stuff up. Is it okay if I use those while I'm here? Sometimes they will say no. They're like, no, I really prefer if you don't. But definitely when you're on your phone, don't be like going on social media, don't be texting, especially don't be like taking pictures or anything like that. Um, Overall, it's probably best that your phone is on do not disturb, on silent, and in your bag. Um, some rotations more than others are going to be looking stuff up, but more commonly than not, just don't be on your phone
And never, ever, ever, even if you are looking something up, don't be on your phone in a patient's room
for sure. Yeah,
when they're around.
yeah.
Um, so these are, I'm just gonna go over these like super quick. So these are more like for you to look at if you happen to be having to do any kind of presentations. The most likely that you would have to do is like an educational case presentation or something on a patient that you may have had. I know my school did that. So just kind of talking about that. And oftentimes, some schools may have you sit in on presentations if you can on certain rotations, and those are great. But I think you'll be less kind of leading those and more just like a member of the panel. And then just to explain the M&M, the morbidity and mortality conferences, those are often very common in like surgical settings or kind of going over things that have gone wrong and how they can fix them. Do you have anything to add here, Logan?
I don't think so. Again, just with presentations, make sure you're actively engaged, even if you find the presentation boring, if it's stupid, whatever. Don't be on your phone. Be sitting there. Be paying attention. Don't be talking. Any of that kind of stuff. Just keep in mind, a lot of people develop bad habits when we're in PA school and we're with our friends all day, not really paying attention. But when you're in those settings, you're sitting, you're listening, you're paying attention.
Yeah. And again, like I'm just going to kind of go through these and then you can always kind of pause it when you're rewatching this if this is something that relates to you. But kind of what Logan was saying, make sure you are having good body language because you can meet a lot of people in these conferences. The person sitting across from you could be your future boss. You have no idea. Especially if it's one in like a topic that you're really interested in. Ask questions at the end or go up and introduce yourself to the presenter because these are marketing opportunities for you. So I definitely recommend that.
Yeah, and every single rotation you're on is a job interview. I got a job offer from almost every single rotation, and you need references. So the people that you are rotating with are going to be your references. You don't want to use faculty from your school. So it's going to be your preceptors that you're using as references for your first job. Make sure you're making a good impression. You're establishing some way of contacting them again in the future if you do need those references. So I would ask at the end of my rotations, only ones that like I felt really well about or like were specialists I want to go into. I'd say like, hi, would you mind if we like exchange contact information just in case I would need like a reference or something like that? Would you be willing to do that?
Yeah.
That's a really important part of your rotation.
Yeah, and I think, at the end of your rotation, that's a lot of preceptors have a lot of students. So how are you going to stand out? Like, how are you going to be one that they remember if they do need a hire in a year? Like, why are they going to reach out, be like, hey, Logan, so we are hiring. Why are they going to think of you? So obviously, it's the way that you act during the rotation, but at the very end of it, you can also always send a thank you note. It takes no time at all to write up a thank you note, highlight, what you learned, not even in detail, just like I really learned the education. I really learned this. I really was thankful that you did this for me. I really enjoyed this rotation. It means so much. And, you can address it to just your preceptor, or if it's an office setting, you can address it to the office. If you have like a niche group there, anything like that. It doesn't take that long and it can be really thoughtful. So,
And like mentioning it too, if you're working with like let's say a PA or an NP and like their attending is around or whatever, you can also say like they did such great work with me. They were really, really nice and helpful. I just want to make sure you knew that. Like always passing it on to whoever's above them is also nice too,
yeah.
for your preceptor. So making sure, they're giving you a review for the people that are above you to make sure you're doing the same for them.
And even like your school will be like, hey, I just want to say, like, I really loved my rotation with, Logan. He was awesome. He really helped me. I would definitely recommend him, if he's available for future students, because it helps everybody. If you have a good preceptor, you should definitely tell them that they're good. Um,
Yeah.
so overall,
And
oh yeah,
sorry, the only thing I was going to add too, and sometimes, especially if a preceptor is kind of inappropriate, it's good to at least mention it to your clinical coordinator. It has happened before that, preceptors just aren't good at teaching. And you always are respectful of that preceptor. You never bring it up to them or anyone that they're associated with at their company. But it is worth mentioning to your clinical coordinator, like, hey, just so you know, I did have this rotation. They kind of left me in the dark a lot. They would tell me to like go sit in a room by myself, X, Y, and Z, whatever.
Yeah,
So
I agree with
giving
that.
you should give that negative feedback only to your program.
Yes.
Don't give it to anyone at that company and don't like mess with their jobs or whatever. But do give that feedback back to your clinical coordinators, because that's something that they're going to keep in mind for like, okay, this is really only a good fit for like someone who's like outgoing and self-directed that can make the most of this rotation, but somebody that needs a little bit more direction won't be a good fit with this preceptor. And it's important for your clinical coordinators to know that.
Yeah, and even if you don't mesh with your preceptor, even if you had issues, thank you for your time and a thank you note. That's all.
Yeah.
You don't have to highlight. If you have no highlights, thank you so much for your time. I really appreciated the things I learned in this rotation. That's
Yeah.
all. But I still would do it. But I think that's
Absolutely.
kind of it for the tutor for this. I think we just wanted to talk a little bit about like who we are, what we do. So we work for Blueprint Prep, which is partnered with Rosh Review. And so we're tutors, and we would love to help you if you feel like you need it. Otherwise, we love hosting these webinars I think we do it once a month now. There's a couple of us. So if you felt like you needed more help in studying for certain areas, if you wanted to download Rosh Review, it's a really great resource. I used it for all of my tests. I think it's pretty popular amongst a lot of programs these days. Yeah, anything to add, Logan?
No, if you do need a private tutor, we are available. There's no shame in needing a tutor either. At the end of the day, the pants is really expensive. If you fail it, you have to pay for it all over again. That's a big cost. So if you're feeling uneasy or anything like that, there are different package levels. You don't have to commit to being with us for a long period of time. If you just want 1 or 2 sessions to go over things, if you want a small group session, we are really flexible on all of that. And you can contact Blueprint and they'll give you all that flexibility. And like Olivia said too, Rosh Review is a really, really, really great resource, especially for the question bank. A lot of times people will study all the content but not do the questions. Questions are really important. You only have a minute per question on your board. So yes, you can answer the question in 5 minutes, but can you answer it in 30 to 45 seconds? Maybe not.
Yeah.
And that's an important
Yeah.
skill to practice.
Test taking is a skill. It is a skill 100%. And so the more you practice, the better you get.
Yeah.
And then this is just kind of going over the tutoring and stuff like that we just talked about. So that last slide was just talking about a giveaway. So one person will win a giveaway based off of who signed up for this webinar, which will be emailed out to everybody, the recording. And you will be notified, obviously, if you are the winner. But it's really exciting. It's kind of a pants power pack questionnaire thing that we talked about in the beginning. So yeah, I guess that's it. It was
Well, we have a few people. Does anyone have any questions that they want to ask us? You can just throw it in the chat. All right.
All right. Well, I guess, you can always email us if you have any questions, email Rosh Review, and they will definitely get back to us on those. But it was great talking to you all. I hope you got something out of this chat.
Yeah, absolutely. And then have a good day, guys. Thanks for coming over and hanging out with us.
Thanks, guys.